Thank you very much, Professor Sultan, members of the organising committee. It's an absolute honour and privilege to be invited to talk at your wonderful meeting. Now, I come from a city of bridges, some very spectacular bridges and a beautiful river, but it's not nearly as spectacular as the Cairo and the River Nile and the bridges over you, and it's always a privilege to come and speak to you in this city. And this is the problem I've been asked to speak about. I'm going to talk about primary aortic rupture, not rupture after endografts. And we all quake at the thought of somebody coming in with no blood pressure, in extremis, with a tense abdomen and being diagnosed with a ruptured aortic aneurysm. It's one of the challenges left for both open and endovascular surgery. It's something we don't always do well, and it's something we always and often feel we could do better. And when somebody has a ruptured aneurysm, these are the three options you have. You can either perform an open repair, you can perform an endovascular repair, or you can palliate the patients. And I would put it to you, there are a series of patients that you shouldn't operate on, those that have been turned down for elective repair, who are frail, who are elderly, and who you're not going to do a service to by repairing their rupture, but they should be in the minority. But as we've heard for most of today, in modern vascular practice, the management of choice is EVAR, EVAR, and more EVAR. If you can do an EVAR on these patients, there's significant evidence they do a lot better than doing an open repair. And this is told to us in the guidelines, and even the NICE guidelines say this for ruptured aneurysms. And it's important that to increase or improve our results, we have these centralized services which you've heard about, and also the development of hybrid suite has really transformed the management of ruptured patients. And just to put it in context, these are our 5-year results. We do about 50 to 60 arterial cases a month, and you can see that we probably only have about between 25 and 15 ruptures a year. So it's a very small part of our practice, and because of that, it's very difficult to get significant experience. And as you can see, with our data, the numbers of ruptures is decreasing, partly because of the national screening program, but also probably the decrease of incidence of aneurysms in the UK. And you can see at the moment we're probably half and half stents and open repair, but we should be putting more stents in. The reason we're not is that we don't have a 24/7 dedicated service to be able to put stents in patients in the middle of the night or at weekends sometime. And these are our results, and as you can see, open on the left and EVAR on the right, and we have a 19% mortality for EVAR and a 39% mortality for open. So those who have EVAR do better, but don't forget this is a highly selected group of patients who are stable and who have anatomy suitable for EVAR on CT scanning. Let me talk a little about randomized controlled trials. There aren't many out there. There's the IMPROVE trial, which looked at 30 centres in the UK and looked at 613 eligible patients with ruptured aneurysms. But the problem with this trial was there was a lot of crossover between the groups of those who received EVAR and who received open. And the reason that trial was done, that a national data set showed that EVAR has a lower mortality, and individual series showed the same. But there were two smaller RCTs which showed no difference at all. And indeed, the IMPROVE trial showed no difference whatsoever. But they thought that maybe women would do better, and that EVAR was cost-effective at 30 days, and also that EVAR patients were discharged earlier. And then they looked at their data with a health technology assessment at 3 years, and basically the 3-year survival for the two groups was exactly the same. The quality of life was good for both groups, and the reoperations were small for both groups. But the healthcare costs were significantly lower for EVAR at all time points. So even the IMPROVE trial is in favour of EVAR now, as well as the registries and local data. And as we've heard just now, the secrets to success are high volume centres. Although there isn't as much as a volume relationship as there is for elective EVAR, you can see there that those doing a significant number of operations have better results and better mortality, and a lot of that is due to the ability to stent these patients rather than to perform open repair. If you have to perform open repair, it is a difficult operation, even for experienced operators. And I'd put to you that in many countries, consultants and professors don't come in and do these operations. Those of the experienced are never there. It's left to the juniors. And every junior has his learning curve and learns how he goes along. And that's not right, but that's the way it is. What I teach my juniors is to get control without causing too much damage. You can easily damage renal veins and duodenum, and teaching them how to put a supraceliac clamp on is extremely important. You don't have to leave it on for long. You can leave it on for 10 or 15 minutes while you get in for renal control. But to my mind, that's a lifesaver, and very few people know how to do it. You need essential instruments like soft clamps. You need balloons in extremis to put up the aorta, whether you're doing an EVAR or an open repair. Tissue glues are amazingly good, as are a lot of the hemostats in the markets. But all of these things you need to do if you're going to get good results. For EVAR, local anesthesia is amazing. Don't be too fussy about which graft you put on or how it's sitting. You just need to stop the bleeding and get the patient out of extremis, and then you can perfect it later on. So it doesn't matter that you have exactly the right graft on the shelf. And I think for all aneurysms, the lessons I've learned is don't over-transfuse them. A little bit of permissive hypotension is good. Venous bleeding kills. You might have a great top end in, and then you roger the iliac veins or the IVC, and that's what often kills a patient, so you've got to take a great deal of care. And also we use laparostomy quite a lot, both for open and also for EVARs who aren't doing well, to reduce abdominal pressure and stop the patients getting multi-organ failure. So ladies and gentlemen, that's me in 1996. I looked a little younger there, and that's our endovascular suite in theatre, which was a second-hand unit bought from Leeds. It lasted about 15 years before it collapsed. We've just this month, had a brand new hybrid operating theatre installed. And with the red collar there, that's my colleague James McCaslin, one of the newer endovascular and vascular surgeons. And ladies and gentlemen, this is the way forward, using this technology so that all patients with ruptures can go straight to an endovascular theatre in a major centre, and hopefully that will improve our results. I don't need to tell you about the guidelines on aortic aneurysms. There's a lot about ruptured aneurysms in there, but it just reiterates what I've had to say. And ladies and gentlemen, there's your beautiful river and one of your beautiful bridges. Thank you very much indeed.